It's May 31st, 2024, and this is the Room Now podcast. Hi, I'm Dr. Jack Cush, executive editor of RoomNow.com. This week, the ACR takes a big swing for the fences. It's going after the Goliath of musculoskeletal public health problems, and that is primary care education. What were they thinking? Could they do it? What do you think? You're going to have to wait until the end to hear what I think. But let's start with a Kaiser Permanente, California study where they review the pregnancy outcomes of lupus patients in a decade, 2011 to 2020, 657 pregnancies, 450 lupus patients. They found, I think, an incredible number. The live birth rate in this large cohort was 74%. That's really good. The other numbers that come out of this, 23% spontaneous abortions, that's been reported before. Very low ectopics, 2%, and 1% or less, actually less than 1%, stillbirths. This is really, I think, good information. This tells you that your efforts in managing lupus patients, getting them under control, everybody being on hydroxychloroquine, are paying off because these largely young female populations are able to have babies like they would have to have or want to have. Things that will influence the outcomes that they found in their cohort study was race, ethnicity, prior history of antiphospholipid antibodies and or syndrome, and then whether or not they had nephritis. Those all influence these outcomes. But this is really, I think, encouraging data. During COVID, we talked about the value of many rheumatic drugs, baricitinib, tocilizumab, IL-6 inhibitors. But we also did a fair amount of reporting about Anakinra, the IL-1 inhibitor, and colchicine, which largely, I think, are viewed by the experts as not having much an effect. But I think that's not the whole story. This particular Turkish retrospective study did an observational cohort analysis of their hospitalized critical COVID patients who were either given Anakinra or just standard of care. So it was IV Anakinra, 100 milligrams, probably for a number of days, didn't say how many. But the bottom line, which was impactful, was that those treated with Anakinra, IV, had less thromboembolic events, less DVTs, less pulmonary emboli, and they had overall better survival. What are we talking about? VTE rates of 5% with Anakinra versus 12.3% with standard of care. That was significant. And I think it speaks to really what Anakinra is probably doing. It's controlling the inflammation, which is toxic to blood vessels, right? Which gives you worse outcomes, especially cardiovascular and vascular outcomes. So I think there might have been a role for powerful anti-inflammatory therapy, IL-6, but also IL-1 in some patients. We don't report enough about fibromyalgia here. There was a ramoseturon. This is like a cousin to Zofran, ondansetron. This is a 5-HT3 receptor antagonist. It's been approved for post-op nausea and vomiting. I think it's been approved or it's been used in IBS, and it has, by some opinions, to be sort of an adjunctive pain therapy. In an 80-patient study, patients were randomized to either placebo or, as a double-blind randomized control trial, were getting IV 0.3 milligrams for 5 days of this 5-HT3 inhibitor. And at the end of 5 days, the fibromyalgia patients who received this therapy had significantly better VAS pain scores. But you know what? And they also had significantly less MD HACs and also Beck depression inventory indices. But that's at the end of the 5 days. When you looked at them out to 28 days, no longer significant. Encouraging, but we need longer term outcomes. We also need more alternative therapies to treat what is a difficult disorder to treat, which is fibromyalgia. I don't know if you saw this week in JAMA, they published a review article. It's really a very good, comprehensive review article on chronic pruritus. And they quote that in our lifetime, 22% of us will have chronic pruritus. Didn't know it was that high, but 1% will present for chronic pruritus, and that seems to make sense. To me, the biggest thing, most important part of this article is the spelling of pruritus. Does it end with a US or an IS? Turns out both are correct, but at least in this JAMA article, done by the experts, it ends in a US. Take that to the bank. So, but they go over pathophys, a diagnostic algorithm, treatment options, alternative treatments. I think this is important for you to download and have, because I don't know about you, but I've got a ton of my autoimmune patients who have chronic pruritus as a problem. Now, pruritus and chronic pruritus is a problem certainly with psoriasis and with scleroderma. But I got a lot of RAs and lupus patients where this is a problem and maybe the thing that drives the patient craziest. So it's good to know this kind of research and resource is out there. 2 big studies of Bimekizumab were published just recently. This is the BHEARD-1 and the BHEARD-2. That's HEARD. These are both 2 large 48-week phase 3 trials where Bimekizumab is put head-to-head against placebo in moderate to severe hidradenitis suppurativa, with significant efficacy being shown, almost like 2-fold responses over placebo rates, and good safety. So again, as I mentioned in the past, there's going to be a lot of drug development for hidradenitis suppurativa, and it's going to benefit the dermatologist. But I'm sure you're seeing them as I've been seeing them, and it's good to know the IL-17 inhibitors do seem to work here, but that also now the dual inhibitor Bimekizumab will work as well. NHANES did a analysis, researchers looking at NHANES data, 2,500 RA patients, and they did a dietary analysis and looked at those people who were on the anti-inflammatory diet as measured by a DI2 score, and then what happened to their inflammatory lab tests like calprotectin and other things, and neutrophil to lymphocyte ratio. And it turns out that if you were adherent to the anti-inflammatory diet, that systemic inflammation, as measured by labs, does seem to go down. We've mentioned before about potential benefits of an anti-inflammatory diet. This is sort of laboratory confirmation of that fact. I think this is another hotly debated area amongst the psoriasis and psoriatic mavens, and that is if you give aggressive therapy, biologic therapy, or JAK inhibitor therapy even, to a psoriasis-only patient, will that prevent the future development of psoriatic arthritis? So in this study, 1,023 PSO patients who were treated with either biologics or not, those treated with biologics had a significantly lower risk of developing psoriatic arthritis. 8.9% on a biologic, 26% if you are not on a biologic. That's a 77% reduced risk by the adjusted odds ratio 0.228. This was significant for those people receiving TNF inhibitors, IL-17 inhibitors, IL-23 or 12/23 inhibitors. Amongst those, the best looked like it was the 23 and 12/23s with a, greater than 80% reduction in risk. The other fact that came out of this was that biologic treated patients had a lower risk of developing peripheral arthritis, but also PSA with peripheral arthritis and axial disease, and both of those were significant. Now, the real question here are cohort studies like this, which have a channeling bias and a selection bias to them, are they valid? I think I've reported a report like this. I know of at least 3 in the past, but I also know that the experts have said that these analyses suffer from bias and may not, in fact, be true. But you know what? Until the right study and the right controls are in play and peer-reviewed, I'm going to say the weight of the evidence suggests that you should be treating mild psoriatic disease, that being psoriasis only, with your best therapy, that being biologics. Why wouldn't you, especially if you could significantly prevent the development of psoriatic arthritis, which occurs in up to 30% of people with chronic psoriasis. I think this is great data. Other important data is this data about metformin lowering the risk of gout. we've reported on Room Now in the past that taking metformin lowers the risk of OA, of RA, of maybe gout. It lowers the risk of complications of things like infection and hospitalization, whether you have an autoimmune disease or not. And again, these are done in people with and diabetes and without diabetes who get metformin. And so this particular study in ARD looked at a cohort of people with prediabetes, a fairly large number, like 25,000 people with prediabetes. And they showed that they propensity matched over 1,000 that got metformin and 1,300 that did not. And after 4 years of follow-up, the risk of developing future incident gout was significantly lower. That was 32% lower, and that was significant. So metformin users, it was 7 per 1,000 patient years. Untreated individuals, 9.5 per 1,000 patient years. But metformin had no effect on uric acid levels, had no effect on CRP. And I think this is a good story. I mean, I don't know about you, and I think I've made the case here, but I get shouted down quite a bit when I say that gout is part of the metabolic syndrome. Clearly, gout has strong associations with components of the metabolic syndrome and with diabetes. And this kind of data has been floated before. But I think that it says that, yes, metformin is good at treating pre-diabetes, but there may also be a great consequence in that you may prevent gout going forward. I think that's important. Lastly, I posted this week that the ACR press release, and congratulations to the ACR for this press release and for all they're doing, even though I'm going to give them some grief. But they've taken on the problem of primary care doctors who are first line and seeing most of our patients long before you're seeing them, sometimes referring them to you, sometimes not fast enough. But they can't be the solution to everything for everyone. And for us to put all the burden of musculoskeletal care on them is probably improper, but still needed because there aren't enough rheumatologists to take care of the 64 million people who are going to have arthritis and musculoskeletal problems in the future. So what did they do? They put up a website. It's called Room for Primary Care, RHEUMFOR, primarycare.org. Look it over. It's an interesting site. It's nicely designed, and they give the first page to either identifying, do you have problems with symptoms and workup? Do you have problems with management? And then you click on those and you go to the sub pages, which is where all the meat is. The menu on the sub page has symptoms and diseases and cases and labs and anti-rheumatic drugs. That theoretically is a menu for the visitor to get some information on. And I think that the design here is reasonable, but may not be blatant enough, because I think people go to websites that are useful to get the answer to a question. I don't think people go to websites, unless you've got the disease, to read about the whole disease A to Z. And I think that's how the ACR has approached this. That's how Artie Cavanaugh and I approached our website, which is called rheumanology.com, plug, where you can look up a symptom, a lab, a drug, a disease. It's all alphabetical and it's all templated, and you can find whatever you want. Under symptoms, they give you 5 symptoms, like rash and Raynaud's and joint pain. Not enough, but it's a start. And then from the symptoms, they kind of go through the workup. So 5 symptoms to choose from, 21 diseases. Okay, it's got lupus, RA, and whatnot. It's got 4 or 5 pediatric diseases like Kawasaki's HSP, etc. It's got rare disorders like IgG4 and sarcoid. What are you thinking? Really? Primary care? They ain't going to come here for this. They may stumble upon this. But there's no address of osteoarthritis, the biggest problem, and the biggest anti-inflammatory problem, gout, 10 million people. Yet we have entries for MIS-C disease in kids, post-COVID. I don't know if that... So I think that this is probably an ongoing work product, that you probably had a healthy number of pediatric rheumatology volunteers to do the hard work of putting this together, and congratulations to them. But this needs to be expanded. This needs to be organized. This needs to be made truly user-friendly. So again, 5 symptoms, 21 diseases, tons of tests. Oh my God, we got 43 or more tests, including tests for signal recognition particle, MI2, and NXP2, and antihistone antibodies. Really? I think we're feeding the wrong monster here. We're feeding the want of the uninitiated and uninformed to do a test to answer all their questions. That's kind of a problem, is it not? Well, it's all there. And there's a big section on drugs, but you know what? It's just lists of drugs without necessarily knowing how to use the drugs. There is something on there about the side effects of drugs, including DMARDs and biologics, commonly used meds, treatment considerations, medication by disease, but these are mainly lists. So an aggressive undertaking by the ACR to address a big, big problem. I think the future of rheumatology isn't going to be solved by our manpower solutions thus far. Too few of you rheumatologists are actually looking into hiring an APP, an advanced practice provider. By the way, this website is for PCPs and APPs, nurse practitioners and physician assistants. But very few of you are looking to hire those folks to join your practice, to expand your services. And you're not going to get any fellows or enough fellows to meet the need going forward. So either you should be educating as best you can your primary care referral base, or referring people to this ACR website and encouraging the ACR to build the end-all of all websites for primary care. Those of you who've been around as long as I have will remember in the late 80s, early 90s, with the introduction of, I want to say Celebrex, because it was sponsored by G.D. Searle, was High Impact Rheumatology, an educational series that led to many lectures around the country. And that slide set, by the way, is a fabulous slide set and should be used by all of you in teaching your primary care colleagues. The ACR should make the High Impact Rheumatology slide set available on its website. As best I can tell, it's no longer there. Should be there. But that was a really good effort, but still didn't have enough, even though it was called High Impact Rheumatology. It was high impact education, really well designed. Good slide set. Definitely doable in short amounts of time. I used them for years in educating residents and fellows who are starting out in learning about rheumatology and patient care. So anyway, congratulations to the ACR for going after Goliath. We need a bigger slingshot to knock that out. Follow us at EULAR. It's coming up in less than 2 weeks. I think you'll enjoy the coverage. Take care.